Hi, everybody. Welcome to this evening's session, an update in diabetes and kidney disease for the primary care physician. I'm Jo Silver. I'm the GP advisor at Western Health, and behind the scenes we have Yvonne from the Northwest Melbourne PHN. Thanks. Next slide, Hannah. So I'd like to begin this evening with acknowledging the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boon Wurrung people, and the Wathaurong people. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. So tonight's session is a collaborative of multiple organisations, so a true diabetes and CKD session. So Western Health, Northwest Melbourne PHN, Royal Melbourne Hospital, Future Health Today program, Western Health Chronic Disease Alliance, the Australian Centre for Accelerating Diabetes Innovations, and the University of Melbourne. So just a little bit of housekeeping before we start for all these sessions. Everybody is muted, and if we ask that you make your questions in the Q&A box only, please don't put them in the chat box because I'm simple and I can't cope with both. The session's going to be recorded and you'll receive a link to the recording and a copy of the slides with the post-session correspondence. So for those of you who are wanting to ensure that you get your CPD and your attendance certificates, can you just please ensure that you've joined with the name you've registered with? If you've got your child's laptop or some other nickname up, please just send Yvonne a message to tell her who you are so as she can ensure that she marks your attendance. We have some fantastic speakers tonight. So our first speaker is Dr. Hannah Wallace from Western Health. So Hannah's a nephrologist in Melbourne's West, and she's undertaking a PhD at the University of Melbourne, exploring the models of care to improve detection and management of kidney disease. We also have Dr. Christopher Preston from Western Health, and he's an endocrinologist with clinical interests in diabetes and modern data analytics and patient interface technologies. And Christopher is also undertaking a PhD in exploring innovative models of care aimed at improving clinical outcomes in diabetes. And our last speaker is Associate Professor Spiros Falanos from the Royal Melbourne Hospital. He's the Director of Diabetes and Endocrinology and Associate Clinical Professor with the University of Melbourne. He's obtained his medical and PhD degrees at the University of Melbourne, and he's authored over 100 peer-reviewed papers. So I hope you'll enjoy the sessions with these speakers. So just a quick update on the Health Pathways Melbourne. So there's lots of pages in Health Pathways about diabetes and kidney disease, and the pathways are a great resource for GPs. So the pathways have been written by GP clinical editors, specialists, allied health, and other subject matter experts, and they give GPs a great resource of evidence-based advice, reduce the variation in care, and also give you the information of how to refer into the various services, both public and private, and lots of resources for patients that you can use.
This is the Health Pathways Melbourne website and login. You can see the homepage with the latest news and
maybe Hannah just click on the next one.
You can type in keywords such as kidney and diabetes.
Oh yeah. Sorry. So the relevant pathways about kidney disease and diabetes are there for you. So you can see there's lots of information to work through. So I'd encourage people to have a look there and become familiar with those, especially if some of those are, if you're not sure about diabetes in pregnancy or other things, then great to have a look in there. Then there's also information on referring. So we know that it's really quite challenging to get some of these patients sorted out. So if you can check these pathways, either on Health Pathways Melbourne, they will link through to the hospital referral guidelines, so as you can ensure that you're sending in the appropriate information to aid in the triaging and earlier review of your patient if that's needed. If you've not registered with Health Pathways Melbourne, you can go onto the website, click to register, and they will send you the links so as you'll have ongoing access to these great resources. Thank you. And I'll hand over to Hannah, who's our first speaker this evening.
Good evening, and thank you so much for coming tonight. As Jo introduced, my name's Hannah and I'm a nephrologist at Western Health, and I have a particular interest in population health, including early detection and management of chronic disease, and as Jo mentioned, currently undertaking my PhD interviewing current kidney disease care in Australia and innovative models for the future. So tonight we'll be covering key aspects of diabetes and kidney disease care for the primary care practitioner. We'll start by reviewing some local burden of type 2 diabetes mellitus and chronic kidney disease, but before moving into an update in diabetes care, including the annual cycle of care, latest treatment algorithms, looking beyond glycemic control, and some practical tips for starting injectables. We will then move into an update in kidney disease, including why diagnose kidney disease, the 4 new pillars of CKD care, and finishing with current referral guidelines. There'll be a dedicated opportunity for questions at the end, but please do post in the chat in the Q&A section as we move through, and we will try and answer them throughout the talk also. So as I'm sure you're all aware, chronic disease is a growing problem and linked to poor health outcomes. Internationally, it is estimated that 10% of the population has CKD, and the population estimates for diabetes are similar. However, it does vary based on geographical region. There is also a rising morbidity and mortality from both conditions. Concerningly, there was no improvement in the global age standardised mortality from CKD between 1990 and 2017, despite many advances in medical care. And over a similar time period, there was an increase in the age standardised mortality from diabetes, which was largely driven by diabetic kidney disease. This is in contrast to other chronic conditions such as cardiovascular disease, COPD, and cancer, which all had significant reductions in global age standardised mortality over the same time period. And without fundamental change in the diagnosis and management, CKD is predicted to be the 5th leading cause of years of life lost by 2040. So closer to home, the Australian data tells us that 1 in 20 have diagnosed diabetes, 1 in 15 have cardiovascular disease, and 1 in 10 have chronic kidney disease, with the true disease rates likely being significantly higher than the reported diagnosed rates. Diabetes is the most common cause of end-stage renal failure in Australia and really should be a preventable cause of end-stage renal failure. These disease maps show the age standardised rates of dialysis, then in the middle type 2 diabetes, and lastly cardiovascular disease in Melbourne. Essentially, the darker the colour of orange and brown, the higher rate of disease. And as you can see, our catchment has a huge burden of disease. And in fact, we have up to double the national rate of diabetes in some population health areas. Cardiovascular disease rates are higher than national averages, despite the younger than average population. And in the west of Melbourne, we have some of the highest rates of patients requiring dialysis nationally, well surpassing over double the national rate. So the good news is that we're now in a position to do a lot more for these conditions than historically. And this involves appropriate testing in patients at risk, diagnosis when appropriate, monitoring for cardiorenal metabolic disease and its complications. And there are also multiple disease-modifying treatments now available for both conditions. Many not only work to improve diabetes, but are also cardiorenal protective. And so I'll now hand over to my colleague, Dr. Chris Preston. And Chris is an endocrinologist at Western Health and will take us through some of the updates in diabetes care before we turn back to my favourite topic of CKD.
Thanks, Hannah. I thought I would start by introducing us to a case for the evening that will follow through, just to introduce the different topics for updates in the diabetes and renal disease. So Mr. MS, as I'm sure many of us have seen, he's a 46-year-old gentleman who's new to our clinic, and he's come in declaring, I wanted to get my diabetes back under control. In terms of his past history, he's had type 2 diabetes diagnosed about 5 or 6 years ago now at the age of 40, and this has already been complicated by hypertension and obesity. This has been managed so far with metformin, gliclazide and perindopril with reasonable adherence, but he does admit to occasionally forgetting to take some of the medications or being a bit slow to refill his scripts. In terms of his social history, he is recently separated from his ex-wife and now has a new partner. He is a truck driver, so he works long hours with poor diet and some difficulties sort of accessing time for exercise in his daily routine. But pleasingly, he's actually a recently reformed smoker and only drinks occasionally on weekends. And on examination, he is quite clearly centrally obese. He's 112 kilograms and 172 centimetres tall, which equates to a body mass index of 38 kilograms per metre squared, and with a waist circumference of 104 centimetres. He's also hypertensive currently with a blood pressure of 150/90, and his point of care glucose is elevated at 10. And on examination of his extremities, he has strong pedal pulses and sensation is intact. So we arranged some baseline investigations as he's new to our clinic, and unsurprisingly, we see that his glycemic control is currently suboptimal with a HbA1c of 8.5%, but otherwise he's not too bad. So his renal function is reasonable. He's got a creatinine of 88 and preserved eGFR greater than 90. He's also currently got a normal urine ACR at 2, and his lipids are reasonable with a total cholesterol of 5.2 and an LDL of 3.2, which could be better, but reasonable as a starting point. So at this time, we should be thinking, well, what should our treatment recommendations be at this stage? So at this point, I thought it would just be a nice reminder to bring up the current guidelines with regards to our annual cycle of care for diabetes, which I'm sure most of you are probably already very familiar with, but just to have it in as a reference as well. So this is taken directly from the Australian Diabetes Society, but it's also available through NDSS and also through RACGP. And really thinking about our treatment principles for each of these parameters, we should be thinking about treating to target. So for our HbA1c, we should be checking every 6 to 12 months for these patients. And although there are some caveats for significant comorbidities or life-limiting illnesses, increasing age where we might not be aiming for this, by and large, we should be aiming for a target of less than 7 for all these patients. For blood pressure, we should be aiming less than 130/80 for all patients with diabetes, and we should be aiming for a normal body mass index, so between 18.5 and 24.9. And we should also be aiming for normal renal function, and that includes both creatinine and urine ACR. And I've just put a little asterisk next to lipids here because at the moment our guidelines are recommending still aiming for total cholesterol less than 4, LDL less than 2, HDL greater than 1, and triglycerides less than 2. But we have seen in the last year some updates out of Europe and the States with tighter targets. For LDL. Can everyone see that screen still?
Unmuted. I've lost you. I've lost the screen.
Sorry, we've just lost the screen. And have we lost Hannah as well?
Lost Hannah.
Okay. Well, what I might do in the interim.
Do you have the slides? Oh, Hannah's back. Here she is.
Apologies for the
That's right.
technical delay. Hannah, are you there?
Yeah, apologies. The internet has dropped.
Okay.
Oh, now.
Try and share the screen.
I should be able to share a screen from here, Hannah.
Great, thank you. It says it's disabled participant screen sharing. I did join with the webinar link though.
Able to share now, Hannah? Apologies, everyone. Technology.
There you go. We should be up and running again.
Just
Is that up and running again?
keep going again. You still with us, Hannah? Still got slides, maybe.
There you go.
Okay. Sorry about that hiccup. Is that working again?
Unmuted. See slides now.
Yep. Okay, so yeah, just as a reminder about the current guidelines for the annual cycle of care of diabetes, and this is taken directly from Australian Diabetes Society, but also available on NDSS and RACGP. A reminder of our treatment targets, so aiming A1C less than 7% for most patients, aiming normal blood pressure less than 130 on 80, aiming normal BMI between 18.5 and 24.9, normal renal function, which includes creatinine and urine HDR, and then the lipids, which at the moment is total cholesterol less than 4 and LDL less than 2. But watch this space because we're seeing in the States and Europe tighter targets with recommendations coming out for less than 1.8 for primary prevention and less than 1.4 for secondary prevention. And of course, it's also important to remember that we should be encouraging and recommending regarding healthy eating, physical activity, as well as smoking cessation where it's relevant, and that's all included there. At this point, I thought I would just bring up the current guidelines with regards to treatment algorithms, and then I'll take us through where each of these have come from, just as a reminder. So if we are unable to achieve our target glycemic control with diet and lifestyle, the next step is usually metformin as monotherapy, unless that's not tolerated or it's contraindicated. If after 3 months is usual sort of review time period, we haven't achieved our glycemic target, the next step then, where in the past we might have suggested sulfonylurea as the next step, clearly now the recommendation is we should be adding in either an SGLT2 inhibitor or a GLP-1 receptor agonist as that next step. And then if both of those are not tolerated or both of those are contraindicated, there is a recommendation that a DPP-4 inhibitor would be the next best add-on therapy before considering a sulfonylurea or insulin. And then, of course, if we're on those two agents and we've tolerated both of those up to maximal dose for 3 months and we're still not at our target glycemic control, then the next recommendation is to add in the other of either SGLT2 inhibitor or GLP-1 receptor agonist if the patient can either qualify for a different indication through PBS or if the patient is in a position to self-fund that second one. Otherwise, it's reasonable to add in the DPP-4 inhibitor to the SGLT2. Of course, we don't recommend the combination of GLP-1 receptor agonist and DPP-4 inhibitor because of the increased risk of pancreatitis with those. And otherwise, it might be at this point where we add in a sulfonylurea or an insulin just for the glycemic lowering effects. And then down the bottom here, there's some specific recommendations about combinations, which I'll go into a little bit of detail about later. But the little light blue box at the bottom is important to remember. As these patients become increasingly complex to manage, we are very happy to see these patients. And we know that we've got, reasonable waiting lists at most of the public hospitals. So if you're getting to that stage, it's quite reasonable to consider referral on to us. So with that last point in mind, I thought I would just bring up a quick reminder of the current statewide referral criteria in Victoria for diabetes patients. So we're very happy to see any patient with type 2 diabetes who's not responding to a combination of dietary and medical management. And this is defined on these criteria as at least 3 glucose lowering medicines with a HbA1c that's persistently above 8%. Also, any patients with type 2 diabetes with significant complications that may affect the way that we choose our therapies or may require multidisciplinary input, so patients with cardiovascular disease, nephropathy, stroke, etc. Also, of course, any patient with diabetes who's planning for pregnancy, we would be happy to see. Any patient with diabetes with unstable control due to other medicines, such as typically steroids or chemotherapy agents that will be adversely affecting their control, or any patients requiring an assessment for a commercial driver's license. And of course, any patient where the exact type of diabetes diagnosed is unclear. So they're the recommendations, and I know tonight is about updates in diabetes care, but I thought I would just very, very quickly go through why we have each of those recommendations before I come to the up-to-date data. Firstly, with regards to sulfonylureas, this is quite old data now, but back in 1998, this was the first big landmark trial showing improvement in glycemic control over a long period of time, actually resulted in reduced endpoints with regards to microvascular complications of diabetes. So this is the UK prospective diabetes study, and this is the first branch of it, which was just under 4,000 patients randomized to either sulfonylurea or insulin or conventional lifestyle measures. And this demonstrated up to 25% relative risk reduction in those microvascular endpoints. But of course, with sulfonylureas, this came at the expense of weight gain and hypoglycemia. So the same study group at the same time. Sorry. I think I've potentially lost control. Hannah, do you want to take control back? There we go. So yeah, the same group at the same time had a sub-study. Did Hannah drop off again?
Here it is, screen's back.
Okay.
I think you're right to keep going, Chris. Apologies.
That's all right. Is it oh, there we go.
Yep.
Doesn't look like it's progressing. Oh, there we go. Yep. So this was the sub-study from that same paper back in 1998, looking at the patients who were randomized to metformin. So this was about 800 participants, followed for 10 and a half years. And this showed a very clear, even better relative risk reduction in those microvascular complications. So a greater effect with metformin than with sulfonylurea or insulin, but without that adverse weight gain or hypoglycemic risk. So this is the basis for metformin being that first-line monotherapy. About 10 years later, this was followed up in 2008 by the ADVANCE study, and this was looking at modified release glycoside and targeting an even tighter glycemic target, so aiming for under 6.5%. And this actually showed improvement in both micro and macrovascular complications if we could achieve that target, but it did prove quite difficult with those previous agents to achieve that. Not much happened for a few years after this, but then in about 2013, we saw the emergence of the DPP-4 inhibitors. And this was in the wake of some adverse cardiovascular signals for some thiazolidine diones, which prompted the FDA to mandate any new medications for type 2 diabetes would have to have rigorous safety data with regards to cardiovascular outcomes before becoming available. So this is the starting point for some really good big number data studies for us. The first one that was studied here was alogliptin in the EXAMINE trial, and this showed an improvement in glycemic control without any increase in adverse cardiovascular events. And around the same time, there was the saxagliptin study, again, reasonable slight improvement in glycemic control, but this actually had a slight increase in heart failure hospitalisation. So those two weren't really picked up in Australia. But shortly after this, in 2015, we saw the TCOS trial for sitagliptin, and this showed improvement in glycemic control, again, without any increase in cardiovascular risk. And then shortly after this, we saw the results of the linagliptin trials, Carmelina and Carolina trials, which showed a slightly comparable, but maybe a bit better reduction in glycemic control without any increased risk. So those two have been really well picked up, but they haven't had any additional benefit beyond the glycemic lowering effects. Around the time of the last of those trials, we saw the emergence of SGLT2 inhibitors, and this is where we really saw the game change. So I'm sure you'd all be familiar already with the EMPA-REG trial. So this was 2015, and this was the first-in-class empagliflozin trial. This was about 7,000 patients randomized to either 10 milligrams or 25 milligrams of empagliflozin versus placebo. And the primary outcome here was a composite of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. And this was done as a safety study, but surprisingly, it was a positive composite primary outcome with a hazard ratio in the top left there of 0.86. So at any time of that 48-month trial, these patients were 14% less likely to have one of these events. And this was driven by, impressively, a relative risk reduction in cardiovascular death of 38%. So we sort of numbers we hadn't seen before. This was followed up then by the dapagliflozin DECLARE trial. So this was 2019 now, even bigger numbers, so 17,000 participants enrolled. And again, this was a positive study with a lower rate of the composite of cardiovascular death or heart failure hospitalisation than placebo by about 17% at any time point. And this was really significantly driven by a lower rate of heart failure hospitalisation. So this has led on to some follow-up studies looking at the benefits of dapagliflozin for other populations. So the DAPA-HF study, the DAPA-CKD, but I won't take all of Hannah's thunder. I'll let her talk to that shortly. And I'll also just mention there are other SGLT2s out there, canagliflozin, ertagliflozin, with similar data, but they're not available in Australia, so I haven't presented those today. And then around similar time that the last of those studies were coming out, we saw the first of these long-acting GLP-1 receptor agonists. So we were already familiar with the mechanism from exenatide from several years ago, but this is new in the sense that it's once a week long-acting. And this first one to come out was the leader trial for the liraglutide. This was 2016, just under 10,000 patients. And again, a primary outcome composite of cardiovascular death, non-fatal MI, or non-fatal stroke. And this was positive with a 13% relative risk reduction. This was then followed up in 2019 by the dulaglutide or Trulicity Rewind trial. And this was again good numbers, about 10,000 participants. And again, a positive study, composite cardiovascular death, non-fatal MI or non-fatal stroke, and about a 12% relative risk reduction. Interestingly though, this study had some secondary outputs that were well described. So we can see on the top left, the HbA1c was significantly lower as we expected. There was an associated improvement in systolic blood pressure. This was at the expense of a slight increase in resting heart rate, which is a common theme amongst the GLP-1s. But in terms of weight, there was a significant weight reduction of 1.46 kilos, which is very significant compared to anything that we'd had before. Around the same time, we started to see the semaglutide trials coming out. So this is from SUSTAIN-6 in 2016, just under 3,500 patients, so slightly less patients, slightly less power. But again, a positive study in that primary outcome, which was a composite of cardiovascular death, non-fatal MI or non-fatal stroke. We can see it really separating quite early on from that treatment. And then if we go into the secondary outcomes here, we can see obviously the improvement in glycemic control. But here the biggest thing was the weight loss that was achieved with these drugs in a relatively short period of time. So for the 0.5 milligrams, we're seeing weight loss of minus 3.6 kilos, and with the 1 milligram, minus 4.9. And so that led on to some further studies with semaglutide at higher doses in the STEP 2 trials. These were looking though at non-diabetic obese patients who were able to achieve up to 15% weight loss. But again, I thought we would focus more on diabetes for tonight. At this point, I thought I would just bring up some practical points about those medications that we should be quite familiar with by now, but very happy to take questions as well in the Q&A. So in terms of the theme of intensifying treatment, whenever we're seeing patients with diabetes on the ward or in our clinics, we are always thinking, could my patient benefit from a different glucose lowering agent? And that might be a switch from something we're already on to another, or the addition of another one. And really what we're teaching our junior doctors and our registrars in our diabetes department is we should be seeing each patient and thinking, is there a good reason why this patient is not on either an SGLT2 inhibitor or a GLP-1 receptor agonist? Because the data is quite convincing. If the A1C is above 7%, we've got significant benefit for non-fatal stroke, non-fatal MI, and overall death from any cause. So that's the simplest way to look at it from our point of view. In terms of some tips when we're initiating GLP-1 receptor agonist therapy, it's really important to remember to inform our patients and forewarn them about the quite real likelihood that they may experience some gastrointestinal side effects. So in some of the studies, it's up to 40% of patients starting on these medications will have this. And some of the numbers are affected in the longer term studies by the dropout because of this. But we do know that if we prepare the patients well, we inform them that it's a possibility, it's likely to happen. If it happens, they will experience it most likely with the first injection. It will wear off after a couple of days, and then it will be lesser effect on the next week, and then hopefully sort of subside with subsequent doses. With semaglutide, it's important that we start low. We start at the 0.25 milligrams. We give a minimum of 4 weeks of that. We make sure it's tolerated, and then we go up slowly to the 0.5 and repeat. And we inform the patient that at each time we go up on the dose, that's likely to happen again. But if we do that and inform the patients, they'll often have some symptoms, but they'll tolerate it and they want to get to that full dose. Also, from our point of view, it's important to remember that we're expecting them to have increased satiety, delayed gastric emptying. They're going to have improved glycemic control overall. So from this perspective, we expect to reduce insulin when we're starting this. So as a rough guide, we usually think of reducing by about 25% of the total daily dose. But we'll often be able to completely wean and cease the insulin over time. When we're thinking about combining therapies, really this is about the incretin therapies again. So we just need to remember that DPP-4 inhibitors and GLP-1 receptor agonists are related. They work on a similar pathway. Individually, they each have an increased risk of pancreatitis, so we don't combine them together. And really, that's probably most relevant when we've got patients on a combination SGLT2 DPP-4 inhibitor that can sometimes be overlooked. Some other practical points. So it's important, of course, to remember our PBS limitations when prescribing these medications. We know that, at least at the moment, a GLP-1 receptor agonist and SGLT2 inhibitor are not approved through PBS as a combination solely for type 2 diabetes management. But with this in mind, we do always look to see, are there other indications for an SGLT2 inhibitor that the patient could qualify for on PBS? And in which case they could potentially have the GLP-1 for diabetes and the SGLT2 for a different reason. But again, I'll let Hannah talk to those other indications. In terms of sick day management for these agents, it's really quite straightforward. So for SGLT2 inhibitors, we inform our patients whenever you're unwell, stop it straight away. wait until you're completely well, eating and drinking normally again before restarting it. And from this point of view, the typical handout we give to the patients is from the Baker IDI, and we can provide this in our follow-up email, the link to this. But I will point out that that does specify SGLT2 inhibitors for patients taking it for diabetes. So if you've got patients on it for a different reason, that might just need to be explained to them why they're getting that information. And with regards to GLP-1 receptor agonists, there is some concern, particularly from overseas, with the longer-acting GLP-1s and elective procedures that might require general anaesthetic, the effect on delayed gastric emptying. So for this reason, there are some recommendations out there to withhold this for 3 to 5 half-lives before any elective procedures, if there is a concern from anaesthetics with regards to that. And otherwise, in terms of deprescribing, so this is probably something we don't do particularly well, but we should be reviewing medications each time we see our patient. And when we're adding in a new medication for diabetes, the rule of thumb is if that medication has not reduced the A1C by at least 0.5% after 3 months, we should reconsider the benefits of it to that individual patient. But the caveat here is that we really, with the newer agents, need to be also taking into consideration both the glycemic and the non-glycemic benefits of that medication. So we wouldn't recommend stopping the SGLT2 inhibitor, but perhaps if the sulfonylurea has not improved things, then there's no added benefit beyond glycemic control. And if it's not doing that job, then maybe it's not helpful. So that's the data of where the current recommendations have brought us. Looking now beyond glycemic control and the newer agents, the first sort of one that has come out in the last couple of years now is this first-in-class dual receptor agonist for GIP and GLP-1. And so when we're thinking about these newer agents, it's important to remember and realise that there is more than just GLP and insulin involved in this process. So just thinking about the enteroendocrine hormones, there is far more here than just insulin GLP-1 that we're currently targeting, and all of these could potentially be involved in, are involved in gastric emptyings, satiety, glycemic control in response to meals, and so these could all be potential therapeutic targets going forward. And so the first in class for this dual GIP GLP-1 receptor agonist is tirzepatide, and this study is already a couple of years old, from 2021, but this is the SURPASS-2 trial looking at this combination. So GIP stands for glucose-dependent insulinotropic polypeptide, so it is dependent on the insulin as well. And this looked at just under 2,000 patients with 3 different doses of tirzepatide, 5, 10 or 15 milligrams. And the comparator here is against semaglutide 1 milligram, which was already the sort of standard of care for comparison at this point. And we can see here on the top left in panel A, we can see that the primary endpoint was HbA1c, and we saw significant reductions of sort of 2 to 2.3 percentage points for the tirzepatide 5 through to 15 milligrams, compared to the already impressive 1.86 percentage point reduction for semaglutide. And then if we look at the bottom left in panel C, this is patients who met the target HbA1c throughout the study period. And we can see that we're getting 82 to 86% of patients with tirzepatide and even 79% with semaglutide achieving that previously very difficult to reach 7% for HbA1c. In the middle panel down the bottom in C, we can see when we change that threshold to 6.5, we're still getting 69 to 80% of patients on tirzepatide achieving that, which would traditionally be our diagnostic threshold for diabetes. And then we're also getting up to 46% with tirzepatide, essentially achieving diabetes in remission, so HbA1c less than 5.7% throughout that study period. So this is numbers and glycemic control that we've not seen before. And the other part to this study was, of course, with regards to weight loss, and this is where the drug has gained even more traction. But we can see here in the top left panel, change in body weight, significant dose-dependent reductions in body weight, with a mean weight loss of 7.6 kilograms for the lowest dose 5 milligrams, 9.3 kilos for the 10 milligrams, and 11.2 kilos for the 15 milligrams, again compared to the already impressive 5.7 kilos for semaglutide. And of course, there's also some benefits with cholesterol as well down there. So thinking about what else is new, you might have read or come across recently the ultra long acting insulins. So I can't see if the screen is progressing or not again.
Unmuted.
There we go. Is it working? So
Unmuted.
the first of these is insulin icodec, or A-weekly, I think it's pronounced. And so this is a weekly insulin injection. This was studied as a non-inferiority study with about just under 1,000 patients compared to daily insulin glargine. And the result was that it was non-inferior to daily insulin. And this has already been approved in Europe. And sorry, I think I jumped ahead there as it's catching up. But it's already been approved in Europe. FDA approval is pending any day now, and no doubt TGA will follow. And the other sort of new topic in this area is in regards to combination injectables. So we've talked about tirzepatide already, but there are multiple agents, thinking back to those endocrine hormones and all the potential targets. So we can see here, we've talked about tirzepatide targeting GLP-1 and GIP. That's already out and available. The next one coming, well, it could be any of these, but one of the ones coming is GLP-1 and glucagon. And we can see already some promising studies in survodutide and cotadutide. So that's an area to watch. Another combination, which is the first-in-class triple agent targeting GIP, GLP-1 and glucagon, has been retatrutide. So that's got some recent publications out. And then otherwise, there's also a combination targeting amylin as well. And then that weekly ultra-long-acting insulin that we were just talking about has now been combined with some of these GLP-1s to make very simple once-weekly dosing for both of those agents. And we're waiting to see some of the outcomes from these combinations. So returning to our case then, we recall he's 46. He came to us wanting to get his diabetes back under control. Very pleasingly, he improved his adherence. He has made an effort to improve his diet to try to fit in some exercise in his day. Given he was already prescribed and taking metformin and gliclazide, and his HbA1c was above 7%, he met criteria on PBS. And weight being his biggest factor, he was keen to trial semaglutide. We started him on this at 0.25 milligrams weekly and slowly up titrated him monthly to 1 milligram. Of course, we forewarned him about the expected initial gastrointestinal upset, which he did experience, but he tolerated that. It's now resolved and he's tolerating the full dose very well. He also caught up with some outstanding screening that was due. He's attended an optometry review, which has confirmed no retinopathy. And pleasingly, he's also seen a podiatrist, which demonstrated no loss of protective sensation and normal pulses and toe pressures, which matched our examination findings. So at about this sort of 6 to 9 month mark, we've organised some follow-up blood tests. And we're not quite there yet, but we're getting there. So his HbA1c has pleasingly come down to 7.0% on the dot. His renal function remains stable with a normal urine ACR still. His lipids are slightly improved with a total cholesterol of 3.8 and LDL of 3. And pleasingly, his blood pressure has also improved to the normal range, 130/75. And he's starting to see the benefits with his weight loss down from 112 to 108. But at this point, he has just welcomed a new baby son with his new partner. And so life gets a bit busy with new parenthood. Unfortunately, he fails to attend his follow-up appointment with us. And then following on from this, he's lost to follow-up for several years. So at this point, I might hand back to Hannah to take over.
Thanks so much, Chris. And hopefully we can see those slides still okay.
Unmuted. Yes, we can see why diagnosed CKD.
Perfect, excellent. Sorry, I'm just going to stay on mute. As you can probably tell, my internet seems to be a little bit unstable. So don't want to rock the boat. So Mr. MS now returns to our clinic after several years. He's now 52 with a young family, and he's moved around a bit and occasionally has asked for some repeat prescriptions when attending various GPs for a sick certificate, but he's not had any blood tests or chronic disease plans as recommended. And a recent visit to the optometrist for new glasses, when he was diagnosed with likely diabetic retinopathy, has prompted a return to the GP. So as we know, he has diabetes and now has the complications of diabetic retinopathy, and he continues to have uncontrolled hypertension. And despite some lifestyle changes and increased activity with the kids, has struggled to shift much more weight. He's intermittently been on his metformin and more recently was put back onto perindopril. And on examination, he remains obese with a BMI of 37. He is hypertensive at 155/90 and has a random BSL of 15. So he goes on to have some blood tests. His HbA1c now is very elevated at 9.5%. He has an eGFR of 59 with a creatinine of 126. So I guess a question for the audience is, does this gentleman have CKD? What are the implications? And what other tests should be done? So chronic kidney disease and its staging is actually a relatively contemporary concept, with the first CKD guidelines being established in 2012. And we've only just received our second international CKD guidelines this year. This figure from KDIGO CKD guidelines is from a meta-analysis which looks at the adverse outcomes by GFR. The panel on the left is what we'll focus on and is staging using GFR. And as you can see, the worse the GFR, the higher the risk of adverse outcomes. This is across all-cause mortality, cardiovascular mortality, myocardial infarction, and stroke, amongst others. The uptick in adverse events in the higher GFRs is not exactly known, and it's thought that it may be in part due to the falsely elevated GFR in those with a low body mass. And so the figure B looks at defining GFR by both creatinine and cystatin C. Cystatin C is not yet readily available in Australia, though it's starting to be used more frequently in the US, particularly using the two combined in some circumstances such as low weight. And this probably results in a better definition of GFR and correlation with adverse outcomes. This figure highlights the hazards ratio for a number of different outcomes, including the first panel with all-cause mortality, AMI at the top, cardiovascular mortality and stroke in the middle, kidney failure requiring renal replacement bottom left, heart failure hospitalisation bottom right, and then the second panel looking at acute kidney injury, atrial fibrillation, all-cause hospitalisation, and peripheral artery disease. These are broken down into stages of GFR and urine albumin creatinine ratio. And as you can see, essentially with both worsening GFR and increasing albuminuria, there are worse outcomes across all measures. As a side note, in this, the UACR is in the US units, and I've placed the conversion in the table below. And I guess another note, the nomenclature has recently changed in the latest Kidney Health Australian guidelines to be in line with the new international guidelines. So microalbuminuria is now called moderately increased albuminuria, and macroalbuminuria is severely increased albuminuria. So I guess I want to place this into perspective. So if we move back to our patient case, he goes on to have his UACR tested, and it comes back as 100 milligrams per millimole, which is equivalent to the US 300 to 999 milligrams per gram. So as you can see here, this puts him at high or very high risk of all of these adverse outcomes, even though his GFR cutoff is just absolute vital importance of not just testing renal function, but also for albuminuria, as this can take from a low risk category to a high risk one. And even if our patient had normal renal function, but moderate or severely increased albuminuria, he would still be in a medium to high risk category. So who should be tested? I guess this is just a brief reminder that patients with risk factors should have a kidney health check every 1 to 2 years. Importantly, a kidney health check requires a GFR, a UACR, and a blood pressure check. And I just want to highlight that UACR is really important and is often not completed. And so as we've just discussed, it's particularly important because it's a prognostic factor for both adverse cardiovascular and renal outcomes. Patients with diabetes and hypertension should be tested yearly, and those with established cardiovascular disease, family history of kidney failure, obesity, smokers, history of AKI, and Aboriginal or Torres Strait Islander patients over 30 should be checked every 1 to 2 years. CKD management can be divided into pharmacological and non-pharmacological management. Briefly, from a lifestyle perspective, we recommend smoking cessation, physical activity aligned with the national recommendations for other chronic diseases, with 30 minutes of 5 days a week, weight reduction if overweight, and a reduction in dietary salt. Secondly, good control of blood pressure. This is now recommended to be below 130 on 80 for all patients, regardless of diabetes or proteinuria. And the latest international KDIGO guidelines actually recommend a further lower target of 120 on 80. However, I think it's worth keeping in mind that this may not be suitable for all patients, particularly the elderly frail patients with postural hypotension. Cardiovascular risk is also very important to assess, as the majority of patients with kidney disease die of a cardiovascular cause. Moderate to severe CKD is consistent with the highest CVD risk category. That is, if your patient's eGFR is less than 45, or they have severely increased or macroalbuminuria, then they are considered at highest cardiovascular risk. These patients should receive statin therapy as per cardiovascular disease guidelines, with an aim for an LDL less than 2 for primary prevention and less than 1.8 for secondary prevention. And finally, the expanding medication options, which have both renal and cardiovascular protective benefits in CKD. I'll spend some more time talking about these. So historically, we really only had risk factor control and the renin-angiotensin system inhibitors to manage chronic kidney disease. However, there has been recent significant expansion in pharmacotherapy available to what is now considered the 4 pillars of CKD management, which includes RAS inhibition, SGLT2 inhibitors, GLP-1 receptor agonists, non-steroidal mineral corticoid antagonists, plus statin therapy for reduction of cardiovascular risk. Population health modelling suggests that if we could adopt these strategies, we could delay and even prevent the need for dialysis in a significant number of people. So Mr. MS continues his journey. He was established on some diabetes medications. His perindopril was up titrated. And as mentioned, his first urine albumin creatinine ratio was 100, and he had multiple repeat similar samples. So we fast forward 3 months and he's been diagnosed with CKD, and his repeat UACR is now 50 milligrams per millimole after a few months on the maximum tolerated ACE inhibitor. He's also had a normal renal tract ultrasound, and urine analysis confirms no red cells or leukocytes. He's actually already now on some of the therapy we would consider for CKD management, but I'll just take us through a stepwise initiation from a renal perspective. So the first step, which I think is well known to everyone, is the initiation of an ACE inhibitor or angiotensin II receptor blocker. Their mechanism of action is to decrease glomerular hypertension, decrease inflammation and fibrosis. And this reduces proteinuria, and in population studies has been shown to reduce the progression of CKD. I guess to note the effects that are over and above their blood pressure lowering effect. So even in a normotensive patient, we would aim to carefully introduce them, starting at a low dose and up titrating as blood pressure tolerates. Historically, it was thought that we might be able to combine ACE inhibitors and ARBs for double the benefit. However, we recommend against this. Essentially, it was associated with increased risks with only minimal benefit. Just some practical tips on starting ACEs and ARBs. Start low and go slow, particularly in the elderly or normotensive patient. It's important to check the UEC 2 to 4 weeks after starting. We do accept up to a 20% decline in function and then recommend further investigation for renal artery stenosis with the Doppler if there's a 30% more decline in function, and the agent should be stopped in this scenario. Patients should also be advised to withhold these medications in the context of prolonged fasting or dehydrating illness. And if a cough develops with an ACE inhibitor, then you can swap it to an ARB. So the next medication class is the SGLT2 inhibitors, and this would be the next step in management for Mr. MS. I guess Chris has already discussed their diabetes benefits. From a renal perspective, we're still learning the exact mechanism of action. The proposed mechanism is via reduction in glomerular hypertension, reduced inflammation and fibrosis, as well as the reduction in circulating volume. In a meta-analysis, they have been shown to reduce the risk of progressive CKD by 37%. And importantly to note, there were similar results between patients with diabetes and non-diabetes. That is, you do not have to have diabetes to have a renal benefit. There was also a reduction in the composite of cardiovascular death or heart failure hospitalisation. This is one of the key figures from the meta-analysis of the SGLT2 inhibitor trials on CKD populations by type of kidney disease. And essentially here you can see in the pooled analysis, it favoured SGLT2 inhibitors, reducing the risk of progressive CKD. And there is a benefit overall, and it was more marked in the diabetes group. However, a further sub-analysis, looking only at patients with proteinuria, defined as a UACR above 22.6, there was actually a similar reduction in progressive renal disease in both the diabetic and the non-diabetic group. And then the analysis in the whole of population, so not just those with CKD, but all the SGLT2 trials considered together, demonstrated a reduction in risk of CKD progression. And so this second key figure looks at mortality and cardiovascular endpoints. And as you can see here, there was a reduction in all-cause death, cardiovascular death, and the composite outcome in both the diabetic and non-diabetic populations. So who to initiate? As per the PBS guidelines, this class of medication can now be prescribed for CKD with or without diabetes. They need to have an eGFR of 25 to 75 and a UACR elevated at 22.6 and less than 565. They also need to be stabilised on the maximum tolerated dose of ACE inhibitor or ARB unless contraindicated. It's also important to note that these medications can be continued even if the UACR improves below the lower threshold after it's been started or the CKD progresses. Noting that in the example of progressive CKD, the patient is likely to also be accessing specialist services which can guide further reuse. Some exclusions on the PBS are patients with polycystic kidney disease, lupus and ANCA vasculitis on current immunosuppressive therapy or transplantation. Other indications, as Chris has mentioned, includes a diabetes indication with an HbA1c over 7% already on other baseline therapy, and also a heart failure indication for heart failures class 2 to 4 in both preserved and reduced ejection fraction. I guess as a side note, the CKD PBS criteria are based off the CKD SGLT2 studies. These studies primarily had patients with proteinuria and an eGFR less than 75, and hence that's why there's the cutoff for those recommendations. There was some non-proteinuric patients, and these results, particularly DAPA CKD, trended towards but didn't reach statistical significance. That said, it's important to note that the trial was stopped early due to the significant benefits, and thus there was a signal to harm in the placebo group. And this meant the recruitment to the non-proteinuric arm was low. And in the pooled meta-analysis of diabetes patients, there does appear to be a renal benefit, even in the absence of albuminuria. And a similar reduction in proteinuria can be seen in patients with higher GFRs. I guess what this means is that I have a patient with type 2 diabetes with an HbA1c greater than 7% and already on other baseline therapy, and they have albuminuria with a preserved GFR or a reduced GFR with normal albuminuria, I would still choose an SGLT2 inhibitor as the next diabetic agent to add to the regime, in the knowledge that it's likely to help reduce the albuminuria and reduce the risk of CKD progression. Just a reminder that SGLT2 inhibitors should not be used for patients with type 1 diabetes. A second question we're often asked is if they can be used in patients with urinary tract infections. I inform patients, obviously, that there's an increased risk of UTIs on SGLT2 inhibitors. However, simple UTIs are not a contraindication. However, I would be cautious to avoid in patients with recurrent pyelonephritis or urinary sepsis, or patients with persistent bacteriuria. It's also very important to discuss the renal benefits with patients and that they are not just used for diabetes. We often have patients who are using these medications for CKD either be told to stop them because they don't have diabetes or get confused when they look it up online. So some tips for starting. SGLT2 inhibitors do increase osmotic diuresis. So to avoid dehydration in a patient who's already on diuretics and not overloaded clinically, I tend to dose reduce the diuretic. Similarly, for patients on multiple antihypertensives with now well-controlled blood pressure, I would consider a small dose reduction in one of the antihypertensives, for example, the calcium channel blocker or hydrochlorothiazide. Similarly to the ACE inhibitors, the SGLT2 inhibitors are associated with a decline in renal function, greatest at the 4-week mark, which then plateaus. So whilst you don't need to routinely check the UEC post-starting, it would be normal to see up to a 20% decline in someone with CKD if you did happen to check. And again, whilst the UAC check is not required post-SGLT2 inhibitor commencement, I guess common sense prevails. And in my own practice, when I have patients with complex comorbidities, particularly those on multiple agents, including diuretics, I'm inclined to review the patient and baseline bloods a few weeks after starting, just to ensure I'm not causing dehydration or hypotension. Chris has already touched on sick day management, but just a reminder that all patients on an SGLT2 inhibitor, whether diabetic or non-diabetic, needs to have it withheld in the context of prolonged fasting or a dehydrating illness such as gastro due to the risk of euglycemic ketoacidosis. So the next agent we have is the mineralocorticoid receptor antagonists. They work by decreasing inflammation and fibrosis. We see a reduction in proteinuria. However, historically, they've often been limited by their side effect profile, particularly their hyperkalemia in CKD. There is a new class called the non-steroidal MRAs, which seem to have less hyperkalemia owing to a more selective drug action. So this is the keynote figure of Fidelio DKD, and this study looked at a non-steroidal MRA in diabetic kidney disease. They found a reduction in the composite endpoint of kidney failure, 40% sustained decrease in GFR, and death from a renal cause, as you can see in panel A. Panel B is the lower sustained decrease in 40% decline of GFR. Panel C is kidney failure, and D, the secondary composite endpoint of death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, and hospitalisation for heart failure. And all of these favoured the non-steroidal MRA. MRAs are typically added for the patient with persistent proteinuria, despite ACE inhibitor or ARB and SGLT2 inhibitor. The non-steroidal MRAs are thought to have less hyperkalemia and are now on the PBS for patients with patients with diabetic kidney disease. The GFR needs to be below 25. Apologies. The GFR needs to be above 25 and the UACR equal or greater than 22.6. Alternatively, in patients not meeting this criteria, the traditional MRAs such as spironolactone can be used, just to be mindful of the potassium. They are safe to start in someone with a potassium of 5 or under, and they need ongoing monitoring. The potassium should be checked at 1 month and then minimum 4 monthly thereafter. If the potassium is greater than 5.5, they should be withheld, the diet adjusted, and could be considered retrialing if the K is 5 or below. And the next drug is glucagon-like peptide receptor agonists. And so, as Chris has discussed, these were developed for the treatment of diabetes and are known for their weight reduction benefits. From a renal protective benefit, their mechanism is not fully understood. However, it's thought that they improve glomerular hemodynamics, increase natriuresis, alter the RAS system, and have anti-fibrotic benefits. And this is in addition to the renal benefits of weight loss. A meta-analysis for GLP-1 receptor agonists in type 2 diabetes found a 14% reduction in major cardiovascular events with a hazards ratio of 0.86, with a 95% confidence interval of 0.8 to 0.93. There was also a reduction in all-cause mortality and heart failure hospitalizations. And importantly, there was a reduction in the renal composite, which included development of severe albuminuria, doubling of serum creatinine, 40% decline in GFR, and kidney replacement therapy or death due to kidney disease. So the FLOW trial was designed to answer this question: if GLP-1 receptor agonists are beneficial in diabetic kidney disease. We do know it was stopped early due to efficacy. The results are being released this weekend at the European Renal Association conference. But as mentioned, we do know they've stopped this trial due to efficacy. So it is anticipated that these will be added to the CKD guidelines for management in the future, and currently are recommended for those meeting a diabetes indication in the International Kidney Guidelines. So I guess back to our case, Mr. MS had an SGLT2 inhibitor added and started on a statin. Unfortunately, however, he was admitted with a non-STEMI and went on to have an angiogram requiring an LAD stent and was commenced on DAPT. His ongoing obesity, he has had some improvement in his HbA1c, but it's still above target at 8.5%. And his GFR has dropped slightly to 52 with a creatinine of 135 and potassium of 5.1 post the angiogram. His UACR has improved somewhat to 35. So a GLP-1 receptor agonist is added again. And I'd like to end the note on a high. So we'll conclude Mr. MS's case there, and that he continued to make improvements in his lifestyle and had ongoing management in the community. However, just I guess to touch briefly on the statewide nephrology referral guidelines, were he to deteriorate. So I guess just briefly, patients where there's concern for glomerulonephritis with a rapid decline in renal function, nephrotic or nephritic syndrome, should be referred to the ED, as to malignant hypertension or the unwell dialysis or transplant patient. And I guess if you're ever unsure, then you can also call the nephrology registrar on call, who can guide you as to whether the patient needs to come into emergency versus urgent outpatient clinic. Outpatient referrals for CKD 4 and 5 are classed as Category 1, in addition to patients with accelerated progression of CKD, nephrotic range proteinuria without nephrotic syndrome, systemic illness or immunological disease with suspected renal involvement. And then the more routine referrals include persistent macroalbuminuria despite appropriate initial treatment of hypertension and diabetes, hematuria with preserved renal function, CKD 3A and B if there's a progressive fall in renal function, particularly in the young patient, uncontrolled or resistant hypertension, and genetic causes of CKD, including polycystic kidney disease. So there's lots of places to get some more information. We've already discussed health pathways, the Australian Type 2 Diabetes Glycemic Management Algorithm, and Kidney Health Australia with a CKD management in primary care that was recently released this year. So the final key takeaways from a kidney perspective is that kidney disease is associated with significant morbidity and mortality, but we can do something about it. A kidney health check involves checking kidney function, blood pressure, and urine albumin creatinine ratio, and should be done yearly in patients at high risk. Our medications have expanded. all patients, unless contraindicated, should be on an ACE inhibitor or angiotensin receptor blocker. An SGLT2 inhibitor should be added in both diabetic and non-diabetic patients if they still have an elevated UACR despite the ACE or ARB. And GLP-1 receptor agonists with cardiovascular benefit should be prioritised in diabetic patients meeting PBS criteria with CKD or CVD. So that's our references. We now welcome you to please start posting any other questions for us in the Q&A section. And whilst this is happening, we'd just like to briefly outline a few programs, both at Western Health and Royal Melbourne, that are designed to help you manage patients with kidney disease and diabetes. So firstly, Western Health is running an exciting implementation trial of a platform called Future Health Today. And I know we have a number of staff on the line from practices involved tonight, so thank you for coming. Future Health Today is a clinical decision support software and quality improvement audit tool that overlies standard general practice software. It has been developed in partnership with the Department of General Practice at University of Melbourne and Western Health. It was designed and developed using co-design by GPs, practice nurses, and practice managers to be intuitive and integrate into general practice workflows. Our trial involves the use of a software alongside a program of support. The modules for type 2 diabetes, cardiovascular disease, and kidney disease are installed, and these provide non-interruptive, real-time clinical decision support directly relevant to the patient sitting in front of you. The software reads a medical record to aid in individualised prompts for testing in those at risk, diagnosis, and evidence-based management. The second part of the software is that it enables practice audits and recalls. Western Health is piloting this program in 20 practices. We'll be providing technical support. There'll also be a clinical education program that will be tailored to the needs and wants of the practice. There's also nurse practitioner support, and this includes outreach support and a phone number for our new chronic kidney disease nurse practitioner. And we're also setting up nurse practitioner clinics, and that's already been established for kidney disease, and a diabetes one should be following shortly. Other potential benefits of the program include CPD points that can be obtained by completing practice audits. We've had really positive feedback from the way it also allows you to easily track MBS items that have been delivered and ensure chronic care disease plans are completed. So we're actually close to full recruitment for the current intake, but if you're interested, please email clinicalsupportfht@wh.org.au, as there may be a second intake in the second part of the year. I'd now like to hand over to Associate Professor Spiros Villanos, Head of Endocrinology at Royal Melbourne, to give a brief update on one of the programs offered at Royal Melbourne currently.
Okay, hopefully you can hear me there. Thanks very much, Hannah. I don't think I can show my face on the video here, but that's okay. Yeah, can you hear me there, Hannah?
Yes, we can.
Okay, fantastic. Thank you. So look, this is a pilot service which we started in September of last year, which is a diabetes remission service. So this is a service aimed at people with obviously very early stage diabetes within 2 years of diagnosis. We might just advance the next slide, thanks. And our model of care is called EndoTracks, which we're doing in collaboration with Western Health. And essentially, we've set up what we call a virtual specialist subacute care gateway, whereby new referrals coming in from primary care and also the ED and inpatient care are coming through this particular service. And it offers a package of 3 endocrinologist telehealth consults in parallel with multidisciplinary care with dietitians and diabetes educators. And the aim is to stabilise patients and provide rapid care and hopefully transition a majority back to primary care within those 3 visits, so we can provide a rapid response as opposed to just overbooking them on chronically overbooked mainstream clinics. So this diabetes remission service sits within this bigger service, and we've got services running for diabetes, bone and thyroid at the Royal Melbourne, and very similar service operates at the Western. Maybe the next slide, thank you. Thanks. So look, we have a very large team involving over 30 people. Me as department head and having conceived it is overseeing the whole service. So from a primary care perspective, when you send a referral through to the Royal Melbourne, it does go through a central triage pool, and then we will determine which stream patients will go to. We will try and prioritise people to go through EndoTrax care, so the telehealth rapid access clinical service, but sometimes if we feel that it's clear that they'll need long-term mainstream care, they may go straight to our mainstream clinics. Now, the diabetes remission EndoTrax service is a shift in thinking because we do want to intervene ideally aggressively and early in people with diagnosed diabetes, and we do stumble across a lot of people with newly diagnosed diabetes as inpatients, and we have the odd referral coming through primary care, and you're more than welcome to refer to our service if you feel you need some assistance with early stage type 2 diabetes. Now, this is sort of the bread and butter of primary care, I would imagine, but certainly we're seeing people are diagnosed during hospital admission. Now, often things get missed, unfortunately, HbA1c levels being 6.5% or higher may be missed. So we're trying to funnel people through this particular service. And I'm running it in parallel with John Wentworth, who you may know as a diabetologist at Royal Melbourne. We can advance, thanks. Okay, so what we're offering is a bundle, actually, if we go back there, thank you, a bundle of care, as we mentioned. So it's a maximum of 3 endocrinologist telehealth consultations for people diagnosed with type 2 diabetes in the last 2 years. And we have a diabetes nurse liaison, a diabetes educator who starts engaging the patient even before the endocrinologists see them. And they also have the opportunity to see the RMH dietitian team. And the aim of this service is to see 4 new patients per week. And today we've seen over 70 patients and performed over 300 consultations. The whole aim of this is not to undertake their diabetes management. It's simply to help devise a plan which is patient-centred. We do co-consultation with the endocrinologist and diabetes educator. And ultimately our plan is to actually do co-consultation with the primary care team. And really we welcome feedback and input from the primary care team, who will have very important insights, and we're hoping to develop this and really lay the foundations for patients being motivated, engaged to address their diabetes early on, especially when they're diagnosed within an acute hospital journey. Okay, we can go to the next slide. So the model of care is purely telehealth. It's different for us because it involves co-consultation. We can have both nurse and doctor on the video call with the patient. It's very, very detailed. We use the Epic EMR system, which enables us to devise very detailed management plans. And hopefully some of you may have seen patients who've already gone through this service. And we have a very explicit aim, which is we're aiming to lose 10 to 15% of weight and an A1C of under 5.7%. Of course, on medication initially, and as you can appreciate from the talks tonight, a mainstay of therapy will be all the hormone agonist pharmacotherapies which are coming away in combination lifestyle intervention. And this is just really laying a foundation such that the plan and the management can actually be executed in primary care. Okay, next slide, I think not too long. What are we doing in this clinic? I can tell you that the mean baseline A1C is not surprising. It's 9%. So this is just some early data. People entering this particular service, that's what they look like. They've got fresh diabetes, so no surprises, and their mean weight is 99 kilograms. This is the first lot of people coming through the clinic. We can advance next slide. And 4 months later, we can see that majority of our patients are already sitting with A1Cs, as you hope, under that diagnostic cutoff of 6.5%. Some actually sitting under 5.7%, and 1 or 2 have actually got off medication already and dropped their weight very significantly. So the weight loss at the moment is 5 kilograms at the 4-month mark. That's on average. We haven't finished, actually, thanks. And many of our patients are starting to get in what we call remission territory. Certainly, if you have somebody under 5.7% on medication, that is remission territory. Of course, remission is actually taking them off the medication and hopefully demonstrating that the HbA1c does not bounce back up. And of course, to achieve a real short or medium-term remission, you'd want to see very significant weight loss, and that's happening in some people. Okay, I think we're almost there. Next slide, thank you. So what we've learned so far is that rapid changes in metabolic outcomes is possible. Co-consultation has been very valuable. This is very patient-centered. The feedback we've had from the patients has been tremendous. They are very engaged and they want this. They want an intensive burst of care. And we realise that sometimes even in primary care, which is in some ways better set up to deliver this, it can be challenging because it does involve a lot of visits and sometimes there are costs associated with that. Okay. Next slide. So final message from me, there are data both from the UK and Australia telling us that this is possible. And if you look at the right-hand panel, those who achieve weight loss in the order of 5 to 10% with diabetes, and these people actually diagnosed with diabetes in the last 6 years, approximately 50%, almost 50% of them went into remission. Now, the definition of remission here was actually very liberal. It was an A1C of under 6.5% without needing oral diabetes medications for 3 months. I would personally say there should be a stricter definition of remission, but nevertheless, this study, the DirectDOL study and the original direct study from the UK is showing this. Okay, I think we can advance. Yeah, just wanted to make you all aware that this service exists. We'd be more than happy to see any patients in the Royal Melbourne catchment area, people you need assistance with who have recently diagnosed diabetes, and you can refer them to our general referral email address or the diabetes endo email address or through the general fax system. So something for you to be aware of. And if anybody would like to overtly collaborate and work with us, we'd be very happy to hear from you. We will be sending out a survey in the next couple of weeks, and we're very grateful if you could all please complete that to give some feedback as to how we can improve this. There's no fees associated with attending this clinic. This is all within the umbrella of the hospital system. Thanks.
Fantastic. Thank you, everyone, for some excellent presentations and lots of great resources. I think it's, really, things have changed. I think, in the past, patients with type 2 diabetes would see it as a failure if they were commenced on medications. So I think we're having to really radically change that kind of thinking, that we need to be quite aggressive at the outset and try and get on top of it and make changes early on rather than let them puddle along and, oh, I'll be good with my diet. And you know that that's unlikely to happen, and we need to jump in with everything. So there was a couple of questions. I think Hannah may have
Yes,
answered a couple of them.
I can.
So the question here, just in case people missed it, is can we routinely start on an ARB rather than an ACE to avoid cough side effects? Or is there a reason an ACE is preferred over an ARB?
Yeah, absolutely. You can start either. So ACE inhibitor or ARB, just not on both. So pick whichever one you prefer. Look, lots of people do prefer starting with ARBs just to avoid that issue of cough altogether. There was also a second question about sort of people stopping ACE inhibitors or ARBs with high GFR. I guess just to clarify, that's a high GFR rather than a low GFR, but yeah, normally we would continue them even in patients who have really good kidney function for their blood pressure control, but also their proteinuric benefits. I guess the only patient that, maybe I would stop it on is someone who becomes really symptomatic and hypotensive on the agent, or a significant more than 30% decline in renal function. But yes, really those agents should be continued. At the opposite end of the spectrum, when we're talking about the low GFR sort of patients approaching dialysis, again, actually, I think most of those patients would be being seen by the nephrology service. There is actually evidence that it's better to keep them on as long as possible. We do sometimes have to take people off due to hyperkalemia, or sometimes we can buy a few extra weeks/months to starting dialysis by stopping one of those agents. But, that's really talking about GFRs in around the 10 mark. Hopefully that answers that question.
Well, that's great. Thanks, Hannah. Are there any other questions? Oh, there might be another one popped up. Here's another one. Does catchment area apply to referral to the endo tracks?
As I mentioned, both Melbourne Health and Western Health have this model of care, so therefore our outreach is very big. Look, at the Royal Melbourne, we don't strictly adhere to sort of a catchment region. And part of it is because it is a bit blurry, and there is actually overlap between us and other health services. So if you're Western Melbourne, Northern Melbourne, Central Melbourne, generally your referral would be accepted. Yeah.
Yeah, and I guess, if the patient's attending one or the other service for some other things, it's probably better if you continue to refer into the one service. Otherwise, we have patients across both, and
yeah, absolutely
makes it a bit tricky. But
yeah, that's right, Jo. And in fact, with EndoTracks, because we're doing it collaboratively with Western Endocrinology, we ultimately want to seamlessly transfer patients between our services. Now, one thing that's restricting us is that we unfortunately have different electronic medical records, which really would have made it a lot easier, but who knows what's going to happen in time. But we are doing a bit of that, and patients will often say, look, I live down the road from the Western or whatever, do I really need to come and see her come through your ED? It's absolutely not. We've got very good colleagues at the Western who can manage things and vice versa. So yeah, I think we're doing it better for sure. In fact, I can give you some data through EndoTracks. We've actually analysed this and actually presenting our data at the national meeting, the Australasian Diabetes Congress. And we looked at diabetes specifically. So at the moment, 60% of people who come through diabetes EndoTracks go back to primary care within 3 visits. 6% are transferred to another health service. Often it is the Western or a private practitioner if they so desire, which means that 30%, about a third or so, are actually entering ultimately the mainstream care after they've had a burst of EndoTracks care. And of that third who go into mainstream care, our mainstream clinics, 50% of those, 55% actually type 1 diabetes, as you'd expect.
Yeah, and I think for us GPs who are referring patients in, I think we need to be selling the message that the hospital's going to help us sort them out, but they'll then be coming back to the GP for that ongoing care if it's appropriate, because we need to kind of free up those slots in the hospital for more patients to be assessed. So I think it's that sort of backwards and forwards. If something goes wrong, we can, we've got a way of fast tracking them back in, but they come then back out to primary care.
That's right, Jo. If you don't mind me just chipping in, absolutely spot on. So in fact, the term that I devised and we're using is intermittent specialist care. What we want is rapid intermittent specialist care. And the problem is that even my colleagues didn't have the confidence to discharge people out of mainstream clinics, for example, because they were concerned about re-entry back into clinics if the primary care team was stuck. But now we have a model of care which allows very rapid re-entry should things not go well after those 3 telehealth consults. So we're much more confident in what we're delivering now. We still have issues, but we're improving.
Oh, that's great. Got another.
Actually, essentially that will be the same model with our CKD nurse practitioner clinic. They're picking up patients who can get onto therapy, get their albuminuria under control, and then go back to the primary care physician. But obviously the door's always welcome if things get out of control.
You need a good acronym, Hannah. Like
yeah, no.
To work on it. I've got another question. Does overweight patients need to be diabetic for a referral, or any overweight can be referred?
For remission, this is?
Yep. Yeah.
Yep. So it's diabetes within 2 years. You certainly need to have a higher BMI, generally BMI 30 plus, but we are accepting people BMIs above 27 newly diagnosed diabetes. Yep.
So I guess we can't just refer in the overweight patients who want to fast track getting some Ozempic, I guess is.
Yeah, we're not going to help with that. You have to have diabetes and we don't have any necessarily better access to drugs. Having said that, I haven't had time to talk about tonight, but we do have multiple hormone agonist RCTs occurring with a whole variety of dual hormone agonists, and that's another big reason you may want to refer, because if we meet people, we can actually slot them in to appropriate clinical trials of dual agonists. We've got a trial at the moment, a synchronized study, which is a glucagon receptor and GLP-1 receptor agonist. We've got trials of GIP receptor and GLP-1 receptor co-agonists. So this is the future. It's a bit like if you refer someone to Peter Mac Cancer Centre, they go into a cancer clinical trial. As the pipeline of drugs is exploding, people will need to be offered participation trials. That's what we're hearing. People want to be in trials, especially with a shortage of Ozempic.
Yeah, I think it's there's great demand out there, and I think patients are feeling the benefit, and they're seeing their friends using it, and those people are having great improvements in their health. All right. Any other final questions?
I can just see one from the Q&A
yeah.
that hasn't been answered yet, which was regarding GLP-1 receptor agonists in underweight patients. So I think we would generally, choose other agents if the patient is underweight to start with, but I imagine this is quite a small percentage of patients. I can't recall having that predicament at all recently. If the question though is defined as non-obese, then if they're normal weight, then yes, we can use the GLP-1 to try to achieve our glycemic target. But of course, we'd be watching the weight, particularly some of the older patients can drop weight significantly.
Great. Thanks, Chris. Any other final questions? No? Okay. Well, thank you very much to our speakers, Hannah, Chris and Spiros. It's been a fantastic session, lots of great information and updates. So there will be a email coming from the PHN.
Unmuted.
With the survey, so it'd be really helpful if people could complete that, give us your feedback, tell us, here it is, what you thought of the session, if other information you would like us to provide with these education events. There will also be a link to the resources, copy of the slides, and if you'd like to watch the recording again, or recommend it to your friends, then it will be on the PHN resources page. Your certificates and CPD will be updated over the next few weeks, so you'll see that on your statements. So thank you, and thanks to Yvonne behind the scenes. We had a few glitchy moments with the IT, but we've all gone pretty well. So thanks, everyone.
Thanks very much.
Thanks, everyone.